Has radiobiology guide treatment options, and I've done a little bit of a change to it. We're going to cover that, but also how do trade-offs guide treatment options for men with low and intermediate risk prostate cancer. Here are my disclosures again. So for the agenda, we're going to go over the macro level trends and treatment comparisons for prostate cancer. We'll go over radiation treatment options. Again, I apologize, this is a little hypo and SBRT heavy. We'll talk about physician and patient selection as well. And so if one looks at NCCN guidelines for how to treat low and intermediate risk disease, I wrote here it's sort of like a choose your own adventure. It's a coin flip. There's significant heterogeneity in all the different treatment options that are available to folks. And so I have sort of the magic 8-ball here saying don't really look at NCCN guidelines. It reflects great treatment heterogeneity, a lot that this meeting covers. And I think the take home is that these are all good treatment options. Depending who you are, depending what you believe and what data set you're going to quote, you're going to feel it's not perhaps equally good, and also depends obviously on the treatment scenario. Overall, we know that active surveillance itself is gaining traction. So this is from the Capture data set on gentlemen with low-risk prostate cancer, showing the growth in appropriately so, active surveillance in the 2000s, where it's become much more common. This is something that's been discussed before, whereas radical surgery and radical radiotherapy has declined for this cohort of patients. This is the results of the PIVOT trial, which folks know about, published in the New England Journal of Medicine 6 years ago. 731 men with prostate cancer who were randomized to surgery versus radiotherapy, observation versus surgery, showing no difference in overall survival or prostate cancer-related survival. There was a trend for higher grade disease that favored surgery. Personally, I find this data set to be extremely informative in looking at patients with observation versus radical surgery, sort of their urinary incontinence and erectile dysfunction over time. And it's a way to use high impact factor publications to guide patient decisions. This is the PROTECT-T study, which was published about a year and a half ago in the New England Journal of Medicine, which randomized 1,643 European men to active surveillance, surgery, or radiotherapy. And at 10 years, there was no difference in prostate cancer-specific mortality. So I think for those of us who treat gentlemen with prostate cancer, this is a pretty big deal to see. In terms of the active surveillance arm, by 3 years, approximately a quarter of the patients did receive definitive surgery or radiotherapy, and by 10 years, that was over half. The metastatic disease rate was 2 to 3 times higher in the active surveillance arm, but the absolute numbers were still low. Amongst the critiques of the PROTECT-T study, one is that 10 years data may not be enough time to see the translation in the increase in metastatic disease to decrease in overall survival, and that only 1% of the patients in this cohort had African or Caribbean ancestry. In terms of quality of life from the PROTECT-T study, none of these results should be too surprising. It showed that patients who had a radical prostatectomy had higher risk of incontinence than with radiotherapy or active surveillance. Those who had radiotherapy had a higher risk of nocturia. Those who had surgery actually did have a higher risk of erectile dysfunction. Obviously, the devil's in the details, and I don't think they go into nerve sparing or not. And once again, not surprisingly, those who had radiotherapy had a higher incidence long-term of bloody stool, which was still low. In terms of the treatment options, I have this sort of suggestive picture here, and the reason for that is I think truly when we counsel patients, the dirty little secret is they all do work, but again, to different degrees. So one of the ways that we sort of frame things a little bit is you have a menu of different treatment options. Obviously, folks who are exquisite experts in their modality believe very strongly in what they do. And so we'll go over a little bit brachytherapy first. There are different types of isotopes that could be used. I should put iridium here for a high-dose rate brachytherapy. And based on the isotope, they all have their own inherent differences in half-life, time to deliver 90% of dose, and energy. There's a lot that's in the literature on sort of the theoretical benefits of using one isotope versus the other in terms of the homogeneous plans or how dose rate may affect outcomes, but in actuality, when one looks at the literature, there doesn't seem to be too much of a difference in overall outcomes that are employed. It really depends who that practitioner is. Dr. Stock and Stone published a multi-center analysis proving that BED, total dose, does matter quite a bit, and other series obviously have done this independently and sort of subsequent to this, and particularly in the Gleason 7 cohort, a higher BED translated to improvement in biochemical outcomes. The data was shared across different institutions, and there are nomograms that now could be employed to really predict the biochemical control rate using D90s or EBRT and other parameters as well. I went over this previously, and Dr. Crook did an amazing job going over the HDR brachytherapy long-term outcomes. In terms of rectal toxicity, there are a number of different series looking at, and this is sort of the Sinai experience with Kirk Schneider, looking at rectal toxicity, grade 3, very low in general, with low dose rate and high dose rate brachytherapy, things that have been presented. But the concept of combination therapy with external beam and brachytherapy causing increase in morbidity, again, in the community at least, isn't surprising. So this is one series that was published showing pretty high rates, and this is very morbid, fecal diversions and urinary diversions. Again, we don't really see this in our practices, but certainly something that should be taken seriously. This was the RTOG that Dr. Stock went over, the 0232, that took gentlemen with the intermediate risk disease and randomized them again to brachytherapy, monotherapy, or combination therapy. Again, no difference in biochemical control rates at 5 years. But I would state that, again, there is a difference in grade 3 toxicity. So in the RTOG, which was presented, there was a difference in grade 3 toxicity, GU versus GI. And again, I would argue this is based on the benefits of having central review of an RTOG protocol. So these were, I don't want to say masters in what they're doing, but these are folks who clearly were extremely attentive to the quality of the implant that they were rendering, and there was central review that was provided. And I would argue that these rates of grade 3 toxicity, while modest, are simply not trivial. Dr. Grimm and Dr. Stock was a co-author on this in the BJUI, characterized biochemical control rates for gentlemen with low and intermediate risk disease. I really think this is a sensational article, again, showing the dirty little secret. All of these different treatments, including surgery and radiotherapy and brachytherapy, all demonstrate excellent long-term biochemical outcomes. Again, depending who you are and your bias and the bias of the individual series, you could skew your interpretation of this data. But clearly, if you're a fan of brachytherapy, you very much enjoy seeing sort of your sort of group here at sort of the highest and with great long-term outcome. And again, intermediate risk disease, all good options. The combination arm really did have excellent long-term biochemical control rates. This is the ASCEND trial that has been covered by Dr. Stock. And just for the intermediate risk patients, looking at combination therapy versus the external beam, there, again, very dramatic improvement in biochemical control, no difference in overall survival at this time. And again, I put this quote here by Isaac Asimov: "The law of conservation of energy tells us we can't get something for nothing, but we refuse to believe it." And so again, that grade 3 toxicity, GU and GI, the GI was not statistically significant, but again, these rates are not trivial. So an 8.1% rate of GI toxicity, or an 18.4%. And obviously, again, the data is in the devil is in the details for that. This was a review by Mac Roach looking at monotherapies versus combination therapy and graphing out GI and GU toxicity, grade 2 and grade 3. And I agree, the ASCEND trial demonstrates toxicity that's way higher than other published reviews or studies, but still, it shouldn't be surprising that it's higher, again, even when you look at the RTOG 0232. I alluded to this in my previous talk, journals that are lamenting the decline in brachytherapy, and I think as a radiation oncologist, it is tragic, and it's an indictment of many parts of our medical care, but it's indisputable that the rates of brachytherapy in at least the United States has appreciably declined over time. This was an analysis through the NCDB of 1.5 million patients, and just over the last 5 years in the 2000s, you could see the decline in brachytherapy radiotherapy as a monotherapy and as a boost that's been somewhat ubiquitous in the United States. And depending on even academic versus community center, there has been a decline throughout in brachytherapy's use. There are some issues. So we know that brachytherapy is extremely operator dependent. This is somewhat of a dramatic example. Folks in the audience are familiar with sort of what happened at the Philadelphia VA. But I would argue anytime, and this is going to be somewhat of an inflammatory statement to make, but when interpreting the ASCEND data, I think anytime you have to qualify who's performing the modality, it somewhat questions legitimacy or the durability of that particular treatment itself. And I know that's an inflammatory statement to make. What I would argue, if you look at all the practitioners on these amazing studies, it's a somewhat of a small group of experts and masters, and they're in the audience today. And I would argue any patient, and I say this with only humility, any patient I were to treat, if they were treated by any of these masters, they would do incredibly well, but that's not the broader community per se. And so these are individuals who have perfected their craft, and the question is, how many of these procedures must one perform before they're at this level? And we know even when one is at this level, and Dr. Crook did show some data on the heterogeneity in treatments. This is one article in brachytherapy looking at the variability in low-dose rate brachytherapy amongst 8 experienced brachytherapists. So they submitted their pre-implant dosimetry for review. And despite having uniform treatment in this one series, the target volume, dose homogeneity, treatment margins, and even the concept of using extracapsular seed placement differed quite a bit. And we know, and this is similar to the prostatectomy data set, that the number of these procedures that are performed by the practitioner do matter. So obviously there is a learning curve, and we heard that through some of the lectures today already. This is one series by Dr. D'Amico that links SEER registries to Medicare claims on 6,700 patients who underwent brachytherapy, and it showed a statistical difference in overall survival and recurrence itself based on the physician volume, so how much brachytherapy they perform. Again, that shouldn't be too shocking. We've already gone over dose escalation with radiotherapy in general with external beam, showing that it improves biochemical outcomes, but there is a slight increase in toxicity. And so we've seen this in different series. This is Dr. Zaleski over at Sloan Kettering looking at grade 2 and higher GI and GU toxicity rates. And not surprisingly, as they started dose escalating at Sloan Kettering, they saw higher rates of GI and GU toxicity. So you don't get something for free. But the rates are pretty modest. So this is their long-term outcome with 86.4 gray, showing good biochemical control rates at 7 years, and again, modest GI and GU toxicity rates. I already went over the hypofractionation regimens before. We went over the RTOG and Profit and CHIP. One of the questions that was asked before in the audience, which I think was an excellent one, was based on some of this data. Do you question the alpha-beta ratio that's sort of been implied? And I think Dr. Crook really highlighted an important point, granted with higher doses, but a lot of radiation biologists would caution us on our use of alpha-beta ratios and BEDs, suggesting that as you give larger doses per fraction, some of the sort of interpretation of that may be different. I would argue that the mechanism of cell kill may also be a little different. So with fractionated radiotherapy, based on 60 years of research, we know it's mitotic catastrophe through double-stranded DNA breaks. And the question is, when you give larger doses per fraction, is there a difference in sort of the mechanism of cell kill? For stereotactic radiation, I went over pooled analysis of 1,100 patients. We talked about dose escalation with Dr. Meyer and sort of long-term outcomes at our institution. And so the point of me framing all of this was to superimpose on this great series once again from Dr. Grimm and others through BJUI. And so if you look at some of the stereotactic outcomes, as I went over already, and you superimpose it, again, the follow-up is much shorter, at least for intermediate risk disease. But you could see, again, the dirty little secret, these are all good treatment options, and it overlays quite nicely. So again, I doctored that photo a little bit. What I think is interesting from a historical perspective is the diffusion, again, of higher doses such as stereotactic radiotherapy. And I'd argue from a historical perspective, it's somewhat odd and unique in the world of radiation oncology in that the academic hospitals were pretty much the later adopters. And so at the inception, and a lot of the literature which I've gone through, it's really been more community hospital practices. Again, you could question sort of the rationale for it, and folks will say, obviously, there's a monetary one, but they really were the early adopters, and the high impact factor publications are evolving, and they are growing. And the way to characterize this in my mind is just to graph out the highest impact factor publications in the world of radiation oncology. And I've sort of put that in table form here. And if you look at the practice-changing publications in the world of radiation oncology over the last 20 years, it studs these high impact factor publications. But as this newer technology develops, and whether you call it stereotactic or cryo or any of them, I think the onus is really to start publishing in higher impact factors publications. And so these are the select seminal publications in SBRT, and I think it's noteworthy that the highest impact factor publication was a negative one. It was the James U. Medicare claims one, suggesting an increase in GU toxicity. So clearly, as technology evolves, it needs to be published in better journals. This is a quote that I wanted to give, and again, the intention of this talk is to be a little bit inflammatory. This is from Dr. D'Amico. So considering the widespread increase in the use throughout the United States, these data serve to heighten awareness to the possibility that this form of prostate cancer therapy may only be clinically efficacious in a select subgroup of patients and possibly inadequate in others. And folks who know this quote will know the kicker of this is that he's not referring to SBRT, he's referring to brachytherapy. And so this was an article published in JAMA in 1998. So again, old data, which we'll go into, but these are patients who are treated at UPenn or the Joint Center, so really centers of excellence, showing vastly inferior biochemical outcome with brachytherapy. Again, no post-implant dosimetry, a supplemental radiotherapy. The entire point of me even presenting this is to simply suggest that with any of these modalities, as we discuss them, and as they evolve, there needs to be some look at maturation. Nobody in their right mind in the year 2018 would question the power and the amazing benefits of brachytherapy. It's just to say that over time, data needs to mature and techniques need to be mature. In terms of patient selection, dose, and delivery, it's a process. Sequencing of different technologies. We could see brachytherapy has been around for a long time, and we've heard lectures from experts in the field still discussing whether or not to combine modality therapy or to use monotherapy. And obviously, we need to have rigorous peer review. So here I say this: it's difficult to compare SBRT with more established treatments. And again, not to be too schlocky with this, but brachytherapy has been around for well over 100 years, and dose-escalated IMRT has been around for quite some time now, whereas robotics and the ability to do stereotactic radiotherapy or dose escalate, a lot of our technology has evolved, but it's been relatively in a recent era. And in terms of development, you have newer technologies that are tested and have demonstrated promise. It's hard to compare them against proven and refined treatments that have existed for quite some time, and you're able to really get the doses just right. Again, thinking to the JAMA article with Dr. D'Amico in 1998 when he published the intermediate risk control rates, clearly it was premature and was before really a good maturation of a type of technology. And so how do you get to mature treatment? One of the questions that I was asked in my previous lecture was, what's the right dose and what's the right sequencing? And the point of this is to show that in last week's Green Journal, in the world of stereotactic radiotherapy, this is still unanswered. And so figuring out whether one should treat daily versus every other day, these are pretty easy questions, but it does highlight the fact that these are not mature technologies or even the doses. So there was a dose escalation trial that not just Dr. Timmermans, but others looking at more modest dosing. So in terms of patient and physician selection, I highlighted the NCCN guidelines and sort of the choose your own adventure approach to treating prostate cancer. And what's difficult is this is what we say to patients: you must choose, but choose wisely. And what patients fear is that the other practitioner, whether that's the surgeon or the radiation oncologist, whoever it is, or their family members will say, well, he chose poorly. In New York City, where I practice, it's sort of a difficult environment because we're all pitching our trade and our practice to patients. So at my center, we advertise, and Dr. Samadi is a high-volume robotic surgeon, is on Fox News. We have New York Presbyterian, Columbia and Cornell. Sloan Kettering is changing how the world treats prostate cancer. And Dr. Stock and Dr. Tawari at Mount Sinai are at an institution where cancer surgery is so effective, even women can feel the difference. Dr. Stock, you're in. What's interesting is that in an academic way, how patients make decisions about their treatment may be somewhat different than how physicians think about optimal ways of providing that treatment. So patients prioritize things a little bit differently than us. They look at cure and salvage options, incontinence, impotence, burns, bowel problems, length of treatment. What matters to a patient may be a little bit different than what matters to us. And so again, you have this menu of options of convenience, invasiveness, toxicity, and efficacy. And I like this picture here, and I know it's somewhat tacky to show Shaquille O'Neal and Jimmy Fallon putting on each other's suits, but I think it highlights the absurdity in thinking that one size is going to fit all. And so based on patient baseline function and comorbidities, their prostate size, previous TERP, the comorbidities in general, their disease aggression, and their preferences, there may be optimal therapies that a Kaplan-Meier curve may not necessarily show, but may be right for that individual patient. I think there's a paradigmatic change that this meeting, which has been so incredible, is clearly showing. Historically, the way of thinking is sort of physician knows best, is that cure trumps everything. And we've had a number of lectures which have been really incredible, going over cure being sort of our northern star and guiding light, but clearly patient quality of life is not something to be trivialized in today's day and age. And some of this sort of way of thinking historically reflected our downstream uncertainty. So our uncertainty downstream after primary modality therapy of the natural history of treated or recurrent disease, where upfront and treated disease is located and the extent of that disease, and the uncertainty, at least from a radiation perspective, on what the salvage options would be and the morbidity that would ensue. And I would argue again that meetings like this provide a light in a previous dark place. And so we're hearing lectures on the benefits of more accurate biopsy data. And when you think about what this data is providing to us, it is providing somewhat of a change in our paradigm approach to treating prostate cancer. So using different ways of identifying more accurately disease, more accurate imaging, the multiparametric MRI. Dr. Stock tomorrow is going to go into all the advanced imaging. And then we've had a number of lectures on partial Glenn cryo and HIFU and brachytherapy, but having better post radiotherapy salvage techniques also will impact our approach. Thank you so much.